Hello everyone. I'm Dr. Abdikhani Ahmed Abdi. Welcome to today's session on pain, sedation, and delirium management in the ICU. These three topics are deeply connected and play a vital role in patient comfort and recovery. In this session, we'll learn how to assess, manage, and prevent pain, sedation, and delirium to ensure better outcomes for our critically ill patients. Here is today's outline. We will begin with pain and its causes, followed by pain assessment, then pain management strategies. Next, we'll discuss sedation in the ICU, and finally, delirium and its management. Each part connects to the others. Together, they help us provide safer and more effective care for critically ill patients. Let's begin with the first part, pain and its causes. Pain is one of the most common and distressing experiences for patients in the ICU. It can come from many sources: medical procedures, underlying diseases, or even simple nursing care. Understanding what causes pain is the first step toward managing it effectively. In the ICU, critically ill patients often experience pain, anxiety, agitation, and even delirium. These symptoms are very common, and they can seriously affect patient comfort and recovery. When we manage these problems effectively, we can improve comfort and safety, help patients tolerate mechanical ventilation better, and achieve better outcomes, with shorter ICU stays and fewer complications. Many patients who have stayed in the ICU describe it as a stressful or even frightening experience. Research shows that 20 to 40% of ICU survivors have no clear memory of their stay. They simply don't remember what happened. On the other hand, about 25% of patients who went through stressful experiences in the ICU later developed symptoms of post-traumatic stress disorder, even years after discharge. This tells us that pain, fear, and stress in the ICU can leave a lasting impact, both physically and psychologically. After understanding how stressful the ICU experience can be, let's now talk about pain, one of the most common problems our patients face. Pain is defined as an unpleasant sensory or emotional experience. In other words, it's not just physical, it's also emotional and psychological. Studies show that between 50 and 80% of ICU patients experience pain or discomfort during their stay. And because of their critical condition, these patients often have hypertension of pain perception, meaning they feel pain more easily than healthy individuals, a condition we call hypernociception. That's why recognizing and addressing pain early is so important in critical care. Now that we know how common pain is in critically ill patients, let's look at the procedures that usually cause pain in the ICU. Even simple or routine interventions can be painful. For example, inserting a peripheral IV, a central line, or a nasogastric tube, and even a simple blood draw can cause discomfort. Other procedures, such as extubation, catheter insertion, or placing an oral airway, can be quite distressing for patients. Even daily care, like mouth care, eye care, or turning the patient, may cause significant pain, especially for those with wounds or limited mobility. And finally, surgical patients often experience postoperative wound pain, which requires careful and consistent pain management. We've seen that many ICU procedures can cause pain, but not all patients experience pain in the same way. Several factors can influence how much pain a patient feels, both at rest and during procedures. Pain at rest is often affected by psychological and personal factors, such as anxiety, depression, younger age, or having multiple health conditions. Patients with a history of surgery may also feel more discomfort even when they're not being touched. Pain during procedures is influenced by how much pain the patient already has before the procedure, the type of procedure itself, and the underlying surgical or trauma condition. Demographic factors like younger age or certain ethnic backgrounds may also make patients more sensitive to pain. So, in short, pain is not only physical, it's also shaped by the patient's emotions, experience, and background. We've talked about what causes pain and what makes it worse. Now, let's move to the next important part, pain assessment. Pain assessment is the foundation of effective pain management. If we don't measure it correctly, we can't manage it properly. In the ICU, assessing pain can be challenging, especially when patients are sedated or unable to communicate. That's why using the right tools and a consistent approach is so important. In the ICU, Pain assessment must be systematic and consistent. We use validated tools to make sure our assessment is reliable. For patients who can communicate, the numeric rating scale, or NRS, is used. We simply ask them to rate their pain from 0 to 10. For patients who are sedated or intubated, we rely on observation tools, such as the Behavioral Pain Scale, BPS, or the Critical Care Pain Observation Tool, also known as CPOT. These scales help us evaluate pain based on facial expressions, body movements, and compliance with the ventilator. It's important to assess pain routinely, every shift, and before and after any nursing or medical intervention. Regular and accurate assessment is the first step to effective pain management. This is the Behavioral Pain Scale, which is one of the most commonly used tools for assessing pain in intubated or sedated ICU patients. It looks at 3 behavioral indicators: facial expression, upper limb movement, and compliance with ventilation. Each category is scored from 1 to 4, with a total score ranging from 3 to 12. A score of 1 means no pain, while a score of 12 indicates severe or maximal pain. A total between 1 and 5 is considered acceptable pain control. This tool allows nurses and doctors to recognize pain even when the patient cannot speak, by observing their facial tension, body movement, and how they interact with the ventilator. Now that we know how to recognize and assess pain, let's move on to the next step: pain management. Pain management is not only about giving medication. It's about understanding the cause, relieving the discomfort, and preventing further suffering. In the ICU, effective pain management improves comfort and safety, helps patients tolerate mechanical ventilation, and leads to faster recovery with fewer complications. In this section, we'll look at both non-pharmacological and pharmacological approaches to manage pain effectively. Before we talk about treatment methods, let's first understand the goals of pain control. The primary goal of analgesia is simple: to provide optimal comfort for the patient. But there are also secondary goals that are just as important. By managing pain properly, we can reduce the body's stress responses, such as increased metabolism, higher oxygen consumption, blood clotting tendencies, and weakened immune function. Effective pain control also helps prevent the development of chronic pain syndromes and allows us to manage anxiety and agitation, especially in intubated patients. So, good pain control is not only about comfort, it directly affects the patient's physiology, stability, and recovery. Now that we've understood the goals of pain control, let's talk about how we can manage pain effectively in the ICU. Pain management includes both non-pharmacologic and pharmacologic approaches. Let's start with the non-pharmacologic methods. Simple nursing actions can make a big difference, such as repositioning the patient, gentle massage, playing soothing music, or simply allowing family presence at the bedside. These comfort measures can greatly reduce stress and anxiety for the patient. Then we have the pharmacologic treatments. Opioids like morphine, fentanyl, and hydromorphone are usually the first-line medications for pain relief in critically ill patients. In some cases, non-opioid drugs such as paracetamol or NSAIDs may also be used, but we must be careful with NSAIDs, especially in patients with kidney problems or bleeding risks. Effective pain management means combining both approaches, addressing the patient's physical and emotional comfort at the same time. While opioids are very effective for relieving pain, they can also cause several side effects, especially in critically ill patients. The most serious one is respiratory depression, where breathing becomes slow or shallow. Opioids can also lead to depressed consciousness, making the patient more drowsy or less responsive. Other common effects include low blood pressure or hypotension, and histamine release, which can cause itching, known as pruritus. Gastrointestinal effects are also frequent, such as nausea and vomiting, and constipation or ileus. That's why opioid use in the ICU always requires close monitoring, to balance effective pain relief with patient safety. Besides opioids, we can also use non-opioid analgesics for pain management, especially for patients who cannot tolerate strong opioids or have mild to moderate pain. Let's look at some common examples. Ketorolac is a type of NSAID. It provides anti-inflammatory and fever-reducing effects. The usual dose is 30 mg intravenously or intramuscularly every 6 hours, for up to 5 days only. For elderly patients, those over 65 years old, or with low body weight under 50 kilograms, the dose should be reduced by half. Ibuprofen is another NSAID with similar properties. It's given 400 to 800 milligrams intravenously every 6 hours. When used short-term, serious complications are uncommon. Finally, acetaminophen, also known as paracetamol, is given 1 gram intravenously every 6 hours, but the total daily dose should not exceed 4 grams. It does not have anti-inflammatory effects, which makes it less effective for inflammation-related pain, but it's generally safe for most ICU patients. After managing pain, the next essential step in ICU care is sedation. Sedation helps reduce anxiety, agitation, and stress, allowing the patient to tolerate medical procedures and mechanical ventilation more comfortably. However, sedation is not about keeping patients deeply asleep all the time. It's about finding the right balance, keeping the patient calm and comfortable, but still responsive when needed. In this section, we'll talk about the goals of sedation, the assessment tools, and how to perform daily sedation interruption to improve outcomes and reduce complications. Sedation plays a key role in ICU management. It helps reduce anxiety and agitation and allows patients to tolerate mechanical ventilation safely and comfortably. The goal of sedation is not deep sleep. Instead, we aim for light sedation, where the patient remains calm but can still be easily aroused when needed. To achieve this balance, we use assessment tools such as the RASS, the Richmond Agitation Sedation Scale, or the SAS, the Sedation Agitation Scale, to monitor the patient's level of sedation regularly. Now let's take a look at the most commonly used sedation medications in the ICU. Propofol acts quickly and wears off fast. It's ideal for short-term sedation, but we must monitor blood pressure and triglyceride levels during its use. Midazolam is a benzodiazepine. It works well for short-term control of anxiety or agitation, but it can accumulate in the body if used for too long, so it should be limited to short durations. Dexmedetomidine is an excellent choice for light sedation. It keeps the patient calm and cooperative, and has a lower risk of delirium compared to other sedatives. An important part of sedation management is the daily sedation interruption, also known as the sedation vacation. This means that once a day, we pause or reduce sedation, but only if it's safe for the patient. By doing this, we can perform neurological checks, allowing us to assess the patient's level of consciousness and brain function more accurately. It also helps with faster ventilator weaning, because the patient becomes more awake and can start breathing on their own earlier. And finally, it reduces the risk of complications, such as prolonged ventilation, delirium, and unnecessary drug accumulation. So, daily sedation interruption is a simple but powerful practice that supports both recovery and safety in the ICU. After managing pain and sedation, the next critical aspect of ICU care is delirium. Delirium is a common yet often overlooked problem in critically ill patients. It affects not only their mental status but also their overall recovery and long-term outcomes. In this section, we'll discuss what delirium is, how to recognize it using proper assessment tools, and most importantly, how to prevent and manage it effectively. Delirium is an acute and fluctuating disturbance of attention and awareness. It can appear suddenly and change over time, sometimes within hours. There are 3 main types of delirium. Hyperactive delirium, when the patient becomes agitated, restless, or combative. Hypoactive delirium, when the patient appears quiet, withdrawn, or less responsive. And finally, the mixed type, which alternates between these 2 states. To identify delirium early, we should assess patients every shift using validated tools, such as the CAM-ICU or the ICDSC. These tools help us detect changes in cognition and alertness, even in intubated or sedated patients. Common risk factors for delirium include older age, dementia, infection, hypoxia, sleep deprivation, and the use of benzodiazepines or other sedatives. Recognizing these risk factors allows us to prevent delirium before it develops. When it comes to delirium, prevention is always better than treatment. Let's start with the preventive strategies. We should always try to reorient the patient, use a clock, a calendar, or even family members to remind them of where they are and what time it is. Encourage early mobility whenever possible. Simple movements, even sitting up or light exercises, can help maintain normal brain activity. We should also promote a healthy day and night cycle. Keep the lights bright during the day and dim them at night to help patients maintain their natural sleep rhythm. Finally, try to reduce environmental noise because rest and quiet surroundings can make a big difference in reducing confusion. Now for the treatment. When delirium occurs, the first step is to find and correct the underlying causes, such as infection, hypoxia, or medication side effects. If the patient becomes severely agitated or unsafe, antipsychotic medications like haloperidol or quetiapine may be used, but only when absolutely necessary and always with close monitoring. Nurses play a vital role in managing pain, sedation, and delirium in the ICU. First, we must regularly assess the patient's status, pain, level of sedation, and signs of delirium every shift and after any intervention. We should advocate for light sedation and encourage daily awakening, so that patients can recover faster and avoid unnecessary complications. Nurses also play a key role in providing non-drug comfort measures, such as emotional support, repositioning, and promoting family presence. Sometimes, a familiar face or gentle reassurance can calm a patient more effectively than any medication. And finally, it's essential to communicate findings clearly with the rest of the ICU team so that care remains consistent, safe, and patient-centered. Together, these nursing actions make a huge difference in the comfort, recovery, and outcomes of critically ill patients. Thank you all for your attention. Today, we've explored the 3 key components of critical care: pain, sedation, and delirium management. Together, these form the foundation of patient comfort, safety, and recovery in the ICU. I hope this session has given you a clearer understanding of how we can assess, prevent, and manage these conditions effectively. Remember, every small action we take, every observation we make, can make a meaningful difference in our patients' recovery. Thank you once again, and I'm happy to take any questions you may have.